Excellent. So hopefully everybody now has figured out how to ask the questions through the application, but if not, maybe raise your hand and somebody can come around and help you out. So that was a great presentation, series of presentations. We have a number of questions. I think one of the ones that, Matt, you kind of hinted it a little bit in the last part of your talk that maybe we can start with is just some of the ethical implications of once these approaches are actually available, both for people who have already opted into care, but also for people who are maybe on the fence. And I'm curious if maybe you want to start, or the panelists can just say very briefly about these are powerful technologies. This is not the same thing as being able to record a brain image, which may or may not say something about someone's future behavior. We're designing systems now that are able to measure behavior in real time. An adolescent who's suicidal. Do you want to comment on how you're thinking about rollout of these platforms as we learn things that we could potentially use?
Yeah. I can, but I was pretty explicit in the last slide saying I didn't want to talk about that. So I'm surprised I start at that point. It's tricky. So on one hand, if we have information that can predict whether a person's going to make a suicide attempt, should we tell them? Of course we should. Of course we should do something to reach out. But we don't know if our interventions are going to help people or harm people. On the other hand, we are all, if you are online in some way or another, you are being monitored all the time. Your data are being collected on you beyond what you are aware. Although if you're in this room, maybe you are aware. And we're constantly being intervened upon to try and sell us things. And so, there's a balance there that I think as mental health researchers and the tech world combine, there's two different sets of guidelines and practices that are used in terms of, we submitted the study I showed you at the very end using COCO to a clinical psychology journal. A lot of the reviewers were saying, whoa, what is this? This isn't a randomized trial. You don't have independent evaluators. Did everybody consent? Did you consent all of these 40,000 people? Well, they completed the terms and conditions, and in the terms and conditions, it says pretty clearly that there's going to be some experimentation. Is that good enough? Do we require more than that? I don't know. I think we've been trying to team up with bioethicists and others to try and work through this in a very clear and transparent way and get to some kind of consensus. I'm curious to hear what others on the panel think about this.
I have a question for the audience, actually. So how many people have tried Google Takeout and looked at your own data?
So does anybody know what Google Takeout is?
Do you even know, how many people know what Google Takeout is? Yeah. Okay. So it looks like almost nobody in here has done that and looked at your own data. I strongly suggest that you do. Google has information, and not all of it's in Google Takeout, but even what you find in Google Takeout will be surprising. They have an enormous amount of information on you. And if you use Facebook, they have a similar thing. So just those two combined bits of data is an enormous amount of information about you. Add on Amazon and then Apple if you're an Apple user, and it's sort of staggering, actually. So it's scary, and I think one of the things that can be a little tricky in this type of situation is that researchers were actually being held to much higher standards than what industry is being held to. And I think what we'd like to be able to do is use all of this data for a positive purpose, for something that people want to opt into and say, that is something that I would like to use for myself. I'd like to be able to use my own data for my own good. And right now, that's not even really a possibility. Often it's not a possibility. Those companies won't give you access to all of your data, but they have it. I had a student who worked at Google this summer and said that you could get access to a data set that essentially has every single time you've opened every app for the last several years for a given individual, and essentially the amount of time that app runs. So think about how much information is just included in that. So I think everybody who works in this space is always concerned about privacy and security and how to deal with it, but I also think that we want to try to be open-minded about the fact that it could do enormous good in health and behavioral health as well.
Yeah, I agree with that, and I also think that we always need to ask ourselves, what assumptions are we making about the population that we're focusing on, right? So it happened to me multiple times that I was making assumptions, right? For example, kids at risk. I was assuming that the parents would not agree to participate, but then we realized that the parents are excited about participating in a study like this because self-monitoring kids at risk, it It's another way to supervise. It's another way to understand what's going on with them. And the fact that they felt like, their kids are being, monitored and being taken care of if something would happen, that was very reassuring for them, so they were very happy to participate. I think same thing about burden. We're assuming that if we're prompting participants a lot of times during the day, that's, always bad, right? People don't want to be interrupted. But like Stephen said, it depends, right? First of all, it depends on how you do it, but it also depends on the population. So for example, Dror Ben-Zev is doing a lot of work on people with serious mental illnesses, and for them, work on mobile health and developing mobile interventions. And for him, for this specific population, they want to be prompted. They want to answer questions. They want people to care, and they want researchers to care, right? So, they view the assessments as actually part of the intervention and something that they need and appreciate. So part of this is always asking ourselves, before we make a decision or make an assumption about a specific population, whether we should or shouldn't use or develop mobile health tools, or whether they're going to accept it or worry about it, first of all, we need to work with the population and figure out, what do they want? What would they accept? And I think that we're going to get different answers than what we're usually hypothesizing.
So I came up in the Netherlands and I studied ethics, and we were developing a program called empirical ethics. So when you talk about ethics of what's right and what's wrong in a field like this, it's usually a bunch of people that aren't the people we're working with, right? So if we want to discuss ethics and what's right and what's wrong and what people feel and know about the way that we're going about this, then we need to talk to the people that we're working with. So I think our entire ethics engine, I've written on this, and there's a bunch of ethics coming up in mobile health. We really do need to rethink it, but we need to rethink it in partnership with the people that we're working with.
Great. Thanks, and also just keep in mind, tomorrow morning we will have a whole ethics session, which will be very interactive. Encourage everybody to show up for that. So one of the questions that's gotten a lot of votes here is, and I think maybe some of the presentations did touch on this, but when will we move beyond EMA to something better? And so I think, just to kind of paraphrase it, I think we've been using this ecological momentary assessment. I think, Stephen, in your presentation, you talked about some fun ways to maybe rethink this. But I think you highlighted that for all of these kind of passive sensor-based studies, you still need something that the user, can actually annotate as being their subjective experience. But this was a question that many people had. So I'm just curious, however you'd like to interpret it. So when will we move on to something better than EMA?
What's wrong with EMA? The idea that sensors are going to give us the ultimate answer, they're going to give us more data than we used to have, but they're not going to solve the problem of the fact that, we still can't measure toothache. And that sometimes a person's perception might be more important than what we're sensing. And sometimes if you put those things together, you'll get new answers to the same questions, I think. So I think that EMA, in some form, like what micro-EMA perhaps is better, but in some form asking the person, what's wrong with that? It's just, we have to know when we have to ask them and when we don't have to ask them. When can we sense things, And as sensors get better, there'll probably be less EMA, but I still think the person is there. Let's not ignore them.
Yeah, so I think if we're successful at building computational models of behavior, then we'll be able to target the EMA questions in a context-sensitive way. And that's going to get us the information we need. And ultimately, it's going to be required for intervention. So where I sort of differ with some of my colleagues in computer science is they want to make black box systems, and you just hand it to somebody and it will recognize everything that they do. And my experience from trying to do physical activity research is that that's never going to get us to where we need to go. And even if you have something like a perfect ambulation detector or walking detector, it never makes a mistake. What an intervention that works for me really needs to know is not just that I'm walking, but why am I walking? Am I walking because I'm walking my dog, or am I walking because I'm walking to get somewhere? It's the context of, and how you feel about it. And certain things like pain, there isn't really going to, I'm not sure what an alternative really would ever be. So I think I think the nature of how we do it can change quite a bit, but I'm not sure what an alternative actually is if you really want to understand what people are doing and feeling.
Yeah, I agree with what Stephen was just saying. So the physical activity field has been using pedometers and accelerometers for years. And there's a whole body of literature about how self-report and whatnot is inherent with bias. However, there's also a whole set of papers on there as well that you can't get rid of that data, as you need the contextual data. So specifically, it's great to get somebody's movement profile, for example. Maybe their movement is less, but that's not necessarily the best indicator sometimes of their health status, because they're moving less intensely, but it's because their relative intensity is higher for where they are with their health status. So you wouldn't necessarily get that from a sensor. You would need to get that from a self-report where somebody's saying their perceived exertion is higher during the specific activity. And so I agree, until somebody can get that contextual information for these health behaviors differently, there's not going to be a way to get away from EMAs or any other sort of self-report metrics.
There's one thing I want to say about, just the focus of the conversation. So it focuses on EMAs for research purposes, right? But we also have to keep in mind that prompting people, asking people to self-report is also a very useful intervention component that is known across multiple areas of behavior change to be extremely helpful. So if we still want people to self-monitor dietary intake, specific experiences for therapeutic purposes, there's just no way around it. We still need to bother people. But I think this is where the methods to make these, these prompts, right, less burdensome for people. I think this is where, we need to go as a field.
I'll ask one that's sort of a provocative question, which is how can academia doing studies of intensive longitudinal data collection compete with the big tech companies like Apple and Google who have all these data at their fingertips?
We better understand psychology and psychiatry. You can collect, it just builds on the last question and the responses to it. You can collect all the sensor data you want, and if what you want to do is predict steps or heart rate, then yes, use the sensor data. If what you want to understand is psychological states, psychological constructs, social, interpersonal constructs, I think you need or would benefit from knowledge from psychological science and related fields to know what those constructs are, how to conceptualize them, how to operationalize them, what interactions to look for, and so on, and what the right interventions are going to be.
The data, I've tried using data from, and some of it's great, but it's not scientifically seeded, right? So I don't have the right questions also being asked that have no financial incentive for a company. So I don't have the data I need to draw the kind of conclusions that you're talking about. Having said that, I wish that there were a closer collaboration between industry and academia. But as it is, the intentions are really important. The intentions with which we gather and use our data are fundamentally different.
So one of the questions that a lot of people have had around the sort of the paper surveys we normally ask people, they often have many dozens of questions. Do you guys see these same kind of clinically validated paper surveys being used in these studies, or is it going to be something that's shorter, small, less questions to kind of reduce the burden? How do you validate against those much longer ones, and do you see these types of work kind of going towards more targeted, fewer questions?
Well, I think in practice what happens is researchers take existing validated surveys, they look for the shortest version that exists, and then they say, now I have to convert that to a mobile phone, and they do their best to not change it, and they have to change it a little bit, and they kind of give up, and then they have something that's sort of close to a validated measure, and they start with that. And I think in a perfect world, there would be more funding for studies to study how to get engagement, how to measure these types of things. Everybody's always trying to do it kind of on the back of some other study, and it's imperfect.
But I think the questionnaire-based method is also imperfect. What we tend to do in psychology, let's say clinical psychology, is come up with, we want to measure depressed mood. We come up with 30 questions that ask about depressed mood in 30 slightly different ways. We have really good internal consistency. And then we compare that to how we do with a separate scale that asks 25 questions about negative mood and say, yes, we get a high correlation between these two. That's bonkers. And so is that really depression? Is that really depressed mood? Well, these two long, wordy scales correlate really highly. We can do the same. We could use a similar logic with EMA questions and say, are we tapping similar psychological constructs? And when people say that they're upset, are they also reporting higher likelihood of being depressed and unhappy and so on? And I think we're better positioned using this approach to say, and what's the relationship between those responses and actual behavior, rather than these long, internally consistent scales. So I think both have their strengths, but both have their weaknesses.
I also think that we always in this field need to ask ourselves, what do we mean by validity, right? Because sometimes, I have a risk indicator that it's clear that, this person is highly likely to lapse and I need to do something now. Do I care if it's depression? Do I care how I call it? I don't care what's it called. It can be a combination of all kinds of things that don't really make sense, right? Theoretically, conceptually. But nonetheless, this is a very clear indicator, messy but clear indicator of risk. So to me, it's valid, right? So we always have to ask ourselves, what we mean by validity.
Can I say one more thing?
Last word.
I think we are looking for the keys under the lamplight because that's where the light is, but I'm not sure the keys are there anymore. In a real-time world, we might not be even asking the right questions. And I think Daniel, right, was talking about how we might go about doing this, starting again with qualitative work, to think about how we ask questions in real time. And I think that it's your student, right? Go see him tonight. He was great. So that sort of thing.
Great. Well, join me in thanking the panel for this really interesting session.